Hello, 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 everyone. Welcome to another episode of BSC, where today we will focus on women's health. Our conversation will span across the female lifespan from little girl all the way up to adulthood. So we are joined by our subject matter expert today, Dr. Akua Afriye-Gray. Hello.
Hi, thank you for having me.
Oh, thank you for joining us. Let's kick it off by sharing with our viewers your career path. Who are you?
Who am I? Wow, this journey started so long ago. I always knew somewhere way back when that I was interested in science. And I remember receiving for my 12th birthday an anatomy set and looking at my mom like, where's my doll? But okay, I'll work with this. But anyway, I went on to study biology at the University of Illinois and did my medical school at the University of Illinois at Chicago. And then I did my OBGYN residency at Georgetown. And then I went out in the world to practice and found that I really liked doing pediatric and adolescent gynecology. So I went back to Washington, D.C. to do a little bit more training in that. How did I end up in women's health? I think women's health kind of called to me from day one. I always knew that, I guess I just remember, as a teenager and as a young adult, my friends and I having questions about our bodies and things like that. And it just didn't feel like there were enough of people who look like me who could answer those questions. So many of my friends went into medicine. Some became pharmacists, some became physicians, but many of us wanted to be able to fill that gap that was present when we were in our training.
So what made you focus specifically on pediatrics and adolescents?
Yeah, so when I was in medical school, I actually had a really hard time deciding between pediatrics and obstetrics and gynecology. But I did OBGYN last, my last rotation. If anyone knows anything about doing your rotations in your third year, that's when you go through and you have a little bit of experience in all the different main big medicine areas. And my last one was OBGYN, and I love the procedural aspect of it. I wasn't 100% sure I liked surgery, but boy, delivering a baby feels like a miracle every single time.
Wow.
So I thought this is for me. This is the thing that I'm going to do. And while I was in my residency, we had maybe one or two lectures on pediatric gynecology, but I didn't even know it was a thing. I won't date myself and tell you how long ago that was that I finished my residency, but it was a while ago. And they really didn't have that subspecialty area. So I went out to practice, and my first area of practice was a rural area where there weren't a whole lot of female gynecologists. So I found, and definitely not Black female gynecologists, I was the only one. So I found myself getting patients that maybe felt a little bit more comfortable in my space. People were bringing me their daughters and their little cousins, and so I found that I felt ill-equipped to handle those problems. So I wanted to go back and get a little bit more training. It probably didn't help that I was in a college town too. So I had a lot of adolescents and young adults who had questions. And I found myself in the same space that I was when I was that age, except for this time I could help them and kind of shepherd them through that part of life.
It's interesting that you say that, because it makes me think of myself growing up. And I think I saw my pediatrician up till I was like close to college. And I just remember that being such an uncomfortable visit to, once I started my periods and things like that, to, I had these terrible cramps, and I just felt uncomfortable talking to a white male about it. And so, I just had to really lean on, family members, the aunts and grandmothers who was giving remedies of how to cope with that. And so I just think that having someone like you, if I had known that growing up, I didn't have to rely on the friend up the street to tell me some of the things that was going on with my body that I was too ashamed to talk to my pediatrician about. So most women are familiar with visiting the OBGYN. Children and adolescents are likely less familiar with this type of physician. So when should a parent consider scheduling a visit with their child with the OBGYN?
Sure. So the thing that you mentioned just about having serious, difficult cramps, things that are affecting your lifestyle, things that are keeping a child from being able to go to school every day, or a young adult from being able to go to work every day. Those are things that are going to affect your lifestyle, not just now, but your future productivity, right? So if something like that is happening to you, then you know that you need to seek assistance. I think some of the barriers, though, are that parents often feel like going to a gynecologist for a teen is a scary thing, right? Like that carries with it so much weight and so many connotations that it makes it difficult sometimes for a parent to acquiesce and say, you know what? Let's go see your pediatrician, because I personally, as a parent, feel more comfortable with that, even though the pediatrician may not be equipped to deal with a lot of those issues. So for a parent, I would say if it's a young woman's reproductive health issue, then see an OBGYN. And if the OBGYN does not feel comfortable taking care of kids, then find a pediatric and adolescent gynecologist. That's where I sit. I sit right in the middle between pediatrics and gynecology. Many of my OB colleagues, which is my primary training, right, don't feel comfortable seeing or even operating on kids that are under age 16. Some people say 12 is their cutoff. And then many of my pediatrician colleagues don't feel comfortable taking care of pediatric gynecology issues. So that's where I sit, right in the middle.
So I have two little girls who I hope to give them, be equipped to give them more support when it comes to just development and becoming a young lady, So what are some questions parents should ask to ensure their child is developing properly to their OBGYN?
Sure. So you really want to pay attention to their development over time, right? So most of us have a sense that girls should be getting their first period around age 12 or 13. If your child is getting to age 14, 15, and they have zero development, they've had no breast development, they've had no hair development, that should be a big red flag. You really need to go see someone about that. Now, pap smears we know are not due until age 21. So it's not that you're going to take your child to get a pap smear because they didn't get their period. These are two separate things, right? We know that getting a pap smear is screening for cervical cancer. But if you're having a developmental issue, that's an assessment in a similar area of the body, but for a different reason. So watch their development. Changes in behavior once they start their period. For some girls, this can cause severe anxiety. They have difficulty, again, with going to school because of the risk of maybe having an accident at school or having severe pain at school, or worry that someone's going to know that they have their period. So those are some of the things that I help to treat as well. So I end up collaborating quite a bit with my psychiatry colleagues, and as I mentioned before, my pediatrician colleagues. So for parents, if your child is asking questions that you can't answer, bring them in. I'll talk to them. I'll talk to both of you. We can get through it together. My hope is that I can help girls kind of transition from childhood to womanhood, right? So I'm going to walk you through that so that you don't find yourself having a very scary exam the first time, right? The first time I had a pelvic exam, it was like you, Dr. Williams. I was with someone who didn't look like me and didn't really explain what was going on. So I was a little bit confused and I couldn't see what they were doing down there. And So, so my strategies for kind of getting through that first visit include explaining and educating and providing resources for parents and for teens.
This is such an important conversation for so many reasons, because you can see young girls start their periods as early as 9 or 10, right? And another aspect of this is that a lot of women and young girls suffer in silence, right? Shantae mentioned like the painful cramps and just not understanding what normal looks like, right? Or hearing from their family members, well, that's just a part of life. You're in pain, you have cramps. That's just part of being a woman, girl.
Mm-hmm.
And so I think, it's important for our viewers to understand, what normal should look like. So can you kind of walk us through what some of the common gynae disorders are for adolescents and women, and maybe some of the warning signs? What are some things that folks should look out for and not ignore and just say, well, it's just part of life. It's just part of being a girl, part of being a woman.
Dr. Patterson-Smith, you're so right. I think that really looking at what's normal first is important. So on average, most women will have a period that lasts 5 to 7 days and use about 3 or 4 sanitary products per day. Some people 5, some people 2, but on average is 3 to 4. If you are soaking through those pads and having to change a pad every hour to 2 hours, if you are having periods that are lasting 8, 9 days, or they're so irregular that you can never tell when you're going to have a period, you need to be seen. Okay. You can have severe problems related to heavy menstrual periods, including anemia. And anemia can affect your cardiac function. It can make you feel fatigued, and it's going to affect your quality of life overall. I would say those are the 2 biggest reasons that I see adolescents painful and heavy periods. But let's go back to heavy periods for just a minute, right? Like if you start having heavy periods the moment you start your period, you need to have a look and see for your child whether they could potentially have a bleeding disorder. That's one of the most common ways that we find genetic bleeding disorders is a child who really has never had any injuries before, but then when they start their period, they are soaking through pads, having to be admitted to the hospital, getting transfusions because of this bleeding. Some kids may have medical problems that precipitate heavy bleeding issues. Say, for instance, a child has aplastic anemia or some other blood disorder, leukemia, cancers. Those things can cause you to have heavy bleeding that affects your reproductive system, even though the primary issue is not the reproductive system. So sometimes people end up in my office not because they're having a reproductive issue, but they're looking for control of that heavy bleeding related to an underlying problem. For the painful periods, one might consider endometriosis. So endometriosis is an issue where someone's tissue that normally would come out every month, that tissue can be found outside of the uterus. That tissue, there are several theories as to why this happens, right? Like one of the theories is that the tissue kind of backflows through the tubes and ends up in the pelvis. That's probably the most common thought. Some people think that maybe when you were in your mother's womb that the tissue actually just kind of migrated to the wrong place, because we all start off as 2 cells that become 1 cell, right? And so out of that 1 cell, tissue forms, all kinds of tissue forms, hair forms, skin forms, teeth form. And so that tissue that forms the inside of the uterus, instead of migrating to the place where it's supposed to go, might migrate somewhere else. And so in rare instances, you may get someone who gets, every time they get their period, they get a pneumothorax, which means that their lungs kind of blow out, I guess, if you want to say it the simplest way. Or they get severe migraines every time they get their period. And in rare instances, you might find endometriosis in the brain. The third possibility for how this endometriosis happens is that perhaps it migrates through the lymphatics. Again, these are all theories. We don't 100% know that this is exactly how endometriosis happens. Most people think that it's multifactorial, that there are lots of different possibilities, maybe related to genetics, as well as some of these factors that I mentioned before. Now, why am I bringing all this up? This sounds complicated, right? And it kind of is. I mean, the thing about it, though, is that if you're having pain from the time that you have your first period, and then every period after that, it's progressively worse. Some people will say that you have had 10 doctor's visits before you actually get diagnosed with endometriosis. And I have diagnosed people from early ages on up into their 20s. And the ones that I meet that are in their 20s have often had those 10 visits. So someone has just told them, just like you said, oh, this is part of being a woman. You need to toughen up. You need to just, go lay down with a hot water bottle, without actually going through the process of trying to figure out whether there's a cause for this severe pain. Again, I would say if something is debilitating and it's affecting your activities of daily living, then you absolutely should be evaluated.
Can we just take that in for a moment? By the age of 10 visits?
Yes.
Diagnosed?
And that's just the people who actually went to figure it, get checked up on. Just think about the women who just lived through it.
Yep.
This is a lot.
It's definitely a problem, right? These are people who could have been diagnosed when they were 13, 14, 15 years old. And now you are 22, 23, finally getting a diagnosis that could affect your future fertility. So when this person is 25, 26 years old and they have met, their Mr. Right, and they are ready to have children, endometriosis can result in infertility. And so many of these things, if you can catch them early, you can reduce the chances that someone would have significant life-altering problems related to their reproductive health.
Yeah, I know as several women who have also had fibroids. And so maybe you can talk a little bit about that. And then I also know some women who have PCOS, and maybe you want to talk a little bit about that, as some other gynecological issues that we kind of experience sometimes, because we all know that as women, we're gonna have, or we should have, some version of a menstrual cycle. But what we don't expect is when it's not quote unquote normal or typical. And so then we have, like some of the things that you've already talked about, endometriosis, these severe cramps. So can you talk a little bit about fibroids and PCOS?
Absolutely. I'll talk about PCOS first, because this is one of the big reasons that I end up seeing adolescents. This is another condition that's typically not diagnosed until much later. With PCOS, and I'm going to describe it the way that I describe it to my patients, because I feel like until I go through this process of discussion, it can be very complicated to grasp, right? We know that much like endometriosis, this is something that's probably multifactorial. We also know that there are multiple different organ systems involved. And I always tell my patients, look, if something says that it's a syndrome, then you can bet that it's affecting multiple different body systems and not just one. So you're coming to me because you're maybe not having a period regularly, but this is a symptom and it's not the cause of the entire overall picture. So the way that I approach PCOS or polycystic ovarian syndrome is really a whole body approach. So now that I've kind of given a little bit of an introduction to that, I'm going to take it all the way back to before you were born, right? So the way that I describe it to my patients is that, hey, look, when you were born, you had all the eggs that you were going to get. And on average, by the time you're born, you maybe have 500,000 eggs. And all those eggs go to sleep. And then when you hit puberty, your body selects a few of them every single month to possibly mature. So I usually actually have whiteboards in my exam rooms. And so I draw this for them so that we can kind of follow together through the process. I think this is really helpful for teens who are used to kind of following along on a computer or on a whiteboard at school. So I usually draw a picture of ovaries, and then I draw one ovary that has multiple little follicles in it, or potentially eggs that have potential to develop, and then one ovary that has an egg that actually completely develops. And I usually talk to them about how if one egg completely develops, that sends signals to the brain back and forth to kind of keep that process going and ultimately tell your uterus that, okay, a pregnancy didn't happen, so now it's time to bleed. On the PCOS side, unfortunately, not all the eggs develop. In fact, often what happens is that you don't ovulate because there is no egg that develops. And so that whole signal cascade that results in having a period every month just doesn't happen. Now, the problem with this is that on the inside of the uterus, actually, I describe the uterus as like a baby house, because really that's what it is. And I always tell people it only has two jobs: bleed and hold babies, right? So when it's acting as a baby house, it's kind of like preparing for a guest, right? It's like when you have someone come over to your house. When I have someone come stay at my house, I prepare the guest room, I get it all ready, I make sure the carpet is nice and clean, whatever I have to do to make that person feel comfortable in that space. But imagine if the person just didn't show up, right? So if the person didn't show up, eventually I start shoving suitcases in there. That room eventually gets a little messy. And the same thing happens inside the uterus. After a time, if no egg matures, no egg comes through, there's no signal that says, okay, that this egg's not coming. Eventually, that inside lining will break down and come out, and sometimes will result in very, very heavy bleeding because that lining of the uterus is very thick. And then other times, people just won't bleed at all for months and months, and sometimes even years. Now, the thick lining of the uterus is a problem because over time, that presents an increased risk for cancer of the inside of the uterus. So obviously, this is a very serious problem. It happens over many years. But I think when you discuss that this is a big systemic problem, most people grasp that, okay, it's time to make some lifestyle changes. So we think that PCOS is a metabolic issue, as I said, and is associated with differences in blood glucose tolerance. We think that even small changes in blood glucose tolerance can affect the ovarian function. And that is what actually results in this lack of development of an egg in the ovary, and perhaps an increased amount of production of androgens or testosterone in the ovaries, resulting in some of the things that come along with PCOS, like acne and hair loss at the crown, or hair growth in areas that women don't typically have hair growth. So it's all connected. And I think approaching it from that perspective helps people to kind of decide what they're going to do about taking care of it. The biggest question I usually get about that is that, okay, well, there's no egg developing and I am not having my period. Does that mean I'm infertile? Well, not exactly. It just means you're subfertile. In other words, you have eggs, they're there and they can be used and we can help you make them mature. But if they are not coming out every month, they're not maturing, we can't predict when you're going to be able to conceive. And so when it's time to conceive, we may need to help you. Or you might get a surprise because you may ovulate when you're not expecting to. So So those are the things I usually talk about with young people and with adults. Second question, I know that was very complicated and detailed, but that's the conversation I have, because I feel like when you leave my office, you should know just about as much about your body as I do. So, so we do have a long, complicated discussion. For fibroids, another long, complicated description. Fibroids are very, very common, especially in African-American women. About 1 in 4 women have fibroids. And I usually will tell my patients, look, if we get 2 more friends in here, one of us has to have fibroids, right? Like, it's going to happen. And if we're both African-American, we get 1 more friend in here and one of us has to have fibroids. So fibroids are kind of like an overgrowth of the muscle of the uterus. And the uterus is made up of 3 layers. We already talked about the inside layer, the endometrium, the part that comes out every month. Then there's a middle layer that's made out of muscle. And then there's a top layer that's really thin and clear that I usually describe as being kind of like pantyhose, right? Like you can see through it, the serosa. Now that middle layer can overgrow, just like you can have a mole on your skin somewhere. That's an overgrowth of tissue. It's still skin, it's just in a different form and it's kind of overgrown. And most of these like skin tags and things like that are not malignant. And the same is true with fibroids. Most of them are not a cancerous issue, even though we call them fibroid tumors. They're benign most of the time. So this overgrowth of tissue can actually be no problem at all, depending on the location. If it happens to be on top of the uterus, it may not cause too much of a problem. If it's small, it may not cause too much of a problem. But if it becomes extremely, extremely large, it can press on your bowel and make it difficult to use the bathroom, press on your bladder, make you have to go to the bathroom a lot. It can push into the inside lining of the uterus. And when it does that, it can make you have heavy and prolonged bleeding. And there are multiple options for taking care of fibroids, from things that are very conservative all the way up to things that are quite drastic. And the earlier you intervene, the more likely you are to be able to have choices in the way that you want to treat it. I think I could get more complicated, but I think that's enough. I've talked a lot.
No, I think you did an awesome job. I just, kind of want to take that and move us forward a few years. We're still spry, but we aren't spring chickens per se. So I'm just curious, as we approach that menopausal age, like, what are some common symptoms that women of our ages and beyond, premenopausal, that they are going to experience that different and distinguish them from, an atypical menstrual symptom?
Sure. As people approach menopause, oftentimes people will complain of heavy, prolonged bleeding. And you may do a full workup with an ultrasound. And, some people will even do an FSH, which is a follicle stimulating hormone. It's a hormone that's made in the brain. And once you enter menopause, it goes really high. Trying to figure out, well, what's wrong with me? Am I entering menopause? Is that why I'm having all this crazy bleeding? Well, the truth of it is that your ovaries are starting to stop working. And so when the ovaries do that, they don't really respond very well to the signals from the brain. And so you can get an overproduction of estrogen. And I always tell people, hey, look, overall, like as far as like an overarching job of estrogen, it makes the lining of the uterus grow. And the overarching big job of progestin is that it causes it to shed. So if your ovaries are making like a whole bunch of extra estrogen, then the lining of the uterus is going to be extra, extra thick. And so every time you bleed, it's going to be super heavy. So there's sort of an old saying in OBGYN, which is you treat hormones with hormones, right? So oftentimes if there is sort of an elevation in those hormones that are causing you to have a thickened endometrial lining and then also heavy bleeding, we might try to manipulate that a little bit by giving you a hormonal treatment. So a lot of women will end up getting IUD, levonorgestrel IUD, which is a progestin IUD that'll try to make that lining thin and reduce that bleeding. Other symptoms that women experience close to menopause include hot flashes. We know that estrogen mediates some portion of the function of the vasculature. And so as a result, it seems like we can't really quite figure out how to keep cool, right? And so women will get hot flashes or night sweats. A lot of women report changes in mood around that time. And this is a gradual process. This isn't like, oh, okay, I turned 48 and then all of a sudden I have all this stuff, although it can be that way. But you may notice when you're 42 that, ooh, why does it feel so hot in here and everybody else look comfortable? And then by the time you're 45, all of a sudden you're like, ooh, I cannot stand this man. I have loved him for 25 years, but I cannot be around him. Or, you get to, 50 and you're like, I cannot sleep through the night, right? So all of these things are associated with what we lovingly call the change of life.
The change of life.
Yes, ma'am.
Dr. Gray, I just want to share with our viewers that while we're going through the change of life, you can still get pregnant.
Indeed. Yes. Thank you for saying that, because oftentimes you may have heavy periods, but you also can have periods that start to spread out a little bit, and people will think, oh, well, I can't get pregnant, let's enjoy these fabulous 40s.
Me and my brother are 30 years apart. Okay.
And I have 2-year-old viewers. So yes.
That's when those bonus babies happen for sure.
Yeah, they do. Yeah, they do.
You still ovulate, you just can't predict it anymore.
That's right. And that's the point. So, hey, viewers, unless you want a bonus baby, keep that in mind.
The other sort of, I guess it's sort of an old saying that we had when I was in my training, and again, this is a little older, is that you're either on prenatal vitamins or you're on birth control. Those only two choices. Yeah, so many things to talk about in women's health. I think, especially for women of color, there have been a lot of issues more recently, and I find that people around me are paying a lot more attention to their health, especially their reproductive health, than they used to.
I surely do hope so, and that is kind of a great segue into one of the questions I wanted to ask about, like normalizing this conversation, right? I think it's still taboo to talk about, subjects that are related to women's health. The periods is still, even in this day, it can be a very uncomfortable conversation. What are your thoughts about how we can go about normalizing these conversations so that people feel more comfortable sharing?
Well, this is certainly a start, right? Having public forums where we can talk about women's health without feeling like, oh my goodness, this is a subject that cannot be openly discussed, right? Now, I have 2 boys and a husband, and so they don't necessarily want to hear about my work when I get home. But when I am in the company of other women, inevitably the conversation turns toward, hey, do you know a good OBGYN that I can see? Or, hey, have you ever had this problem? I had that problem. So making it something that we can discuss, we don't have to get dirty with it, right? Like we don't have to use, terms that might feel difficult or offensive, right? I don't have to say uterus all the time. I can say womb if that's more comfortable for you, right? So I think that is the biggest start, just addressing that there is an issue. I think one of the most wonderful developments over the last few years is people talking about menstrual equity. I don't know if you all have heard this term before, but really it has to do with folks who can't afford to buy sanitary products, right? So this becomes a great burden. I mean, you would never think that in this day and age that this is a burden for people, but it really is. If you look at women's health products, they tend to be more expensive than men's health products. And this is something that we can't help. We need it every month. What are you going to do, right? So
I've heard this. Are you referring to period poverty? Like I've heard the term period poverty.
that is very similar. It means essentially the same thing. Yes.
Wow.
And not just people in other countries. We're talking about people in our own backyard. Mhm. So sometimes you may find, depending on what organizations and things that you participate in, people collecting menstrual products to distribute to women who may be unhoused or in difficult situations, difficult financial situations.
Yeah, I think a lot of times women's products and women's health issues get treated as if they are illnesses. Our periods and our menstrual cycles are not an illness. It's a condition of our livelihood and our, just being a woman. But like you said, those products, they get taxed. When we're pregnant, we're treated like we're sick. We're not sick, we're pregnant. And even some of the things that we need, you can't even get on your FSA card. I remember a little while ago, there was legislative talk about the period tax, right? With the tax that's on our sanitary products and things like that. Why aren't they and the thing about it is, well, men don't have to think about these kinds of things. So for them, they don't see it as a necessity. I've actually seen some phrases calling it a luxury. It's not a luxury, it's a necessity.
It's anything but a luxury.
Right. Yeah, exactly. So I'm gonna ask this question because you've talked about your training several times, and just thinking about your medical education and what you see in medical education today. When we think about these women's health issues and the things that women have to endure medically, what do you see as some of the most pressing needs in medical education to begin to address these issues and reduce some of these disparities?
Well, one of the things I can say with confidence is that the field of OBGYN has been really good about pressing for education in women's health. So one of the organizations I belong to is the Association of Professors of Gynecology and Obstetrics. And every year I have seen them be on the forefront of discussing some of the issues that affect who we are and what we need as Black women. So, for example, I actually just came back from that conference, and many of the sessions were about health inequity and were about why do we have so few African American physicians? What's happening in the pipeline that our folks are not able to get out there and go into the specialties. So I think what really needs to happen in medical education is better support of African American candidates for medical degrees, as well as African American candidates for the specialties. One of the prominent issues that's been in the news is African American mortality, maternal mortality rates, and maternal morbidity rates. When you really look at it, it's probably more of a systemic issue, right? So actually one of my residents just presented a talk today about the disparity in testing people for drug use on labor and delivery. So in her study, she found that African-American women were tested more frequently, even though they didn't necessarily have an indication. So if you look at all the people who didn't meet criteria for testing for drug use, for some reason, our folks were being tested more for no good reason. So I guess what I'm getting at is that there is systemic racism everywhere. And the more we learn how to listen to African-American women when there's an issue, when there's a problem, I think we will reduce those numbers, those maternal mortality numbers and those maternal morbidity numbers. And that's across the board for all I wouldn't even say that's an illness, but for all conditions, medical conditions that we treat. I think if you really looked at it with a critical eye, you would find that we are treated differently, much like we have been in other areas of our lives. And having someone who looks like you taking care of you, I think makes a difference. So encouraging people of color to pursue careers in medical education, as well as in medicine overall, I think is really important. In fact, that's one of the areas of my own study is medical education. Why do people choose to go into medical education? Is it because they even know that it's a field? Because I suspect that a lot of people don't even know that medical education is a track that you could pursue when you are in medical school, right? Like I have seen people who have pursued medical education from the day they entered medical school, and they do not look like me. Like they knew from day one that, okay, I'm going to be a teacher of medical education. And so let me go ahead and seek out the clerkship director. Let me go ahead and seek out the program director and shadow them and research with them and find out how they do their job so that when it's my turn to make a selection, that this is an option for me. And I just don't think that that was even a thought for me at that early stage of my career. I had no idea that I could be the person showing somebody else how to take care of a patient, right? So if I'm the one who teaches someone how to take care of a Black woman, there are nuances to how I'm going to teach that are going to be different from someone else who's teaching that same subject matter. So I feel like we have to get granular. We have to get deep down in there and be a part of all processes of medical education and growth for our learners.
This is so critical, and this is why we do what we do.
Indeed.
So that the next, Black girl, Black woman that goes to med school hears this story and knows that that track is an option, right? I mean, it's all about seeing and understanding and the exposure. The exposure. Wow. Well, listen, viewers, I think if you don't take away anything else from this episode, take away advocacy. If your physician is not hearing you, right? Dr. Afriye Gray said your physician needs to hear you. Your concerns are real. There's no medal for suffering in silence, right? You don't get a medal. Like, I know we like to talk about checks in this era. There's no checks, there's no coins, there's no nothing that comes along with suffering in silence. Have that conversation with your physician. And if your physician is not listening, find one that will. Find one that will. Well, Dr. Afriye Gray, we thank you so much for joining us on this episode of the Black Scientists Cooperative. I'm so inspired by your passion, by what you do, your drive, just everything. And, this has just been, I always say this at the end of every episode, but this has been eye-opening for me. Sure. I wish I could fly my daughters to where you are, so that so that they could see you draw on the whiteboard and explain all these things, because just your passion and your sense of care, just is unrivaled. And I thank you for that. I thank you for your commitment to our community. I thank you for your commitment to adolescents and peds. Thank you for being a guest on our show. And until next time, viewers, thank you for joining us for the Black Scientists Cooperative.
Thank you
Take
so
care.
much for having me.
Deep flows like a breeze flowing through me, from my head to my feet. Your love runs smooth, ooh, it soothes, and you're making life right. I'm so glad that you're mine, you're mine.